everyone, I just want to take a few minutes into I'm going to say quick, my goal is an hour video, just overviewing what we talked about this first week of class. So when class started this week, we talked about what is the difference between mental health and mental illness. We looked at some of these quick examples, Robin Williams, Chester Bennington, One Flew Over the Cuckoo's Nest, how we used to depict mental health and not even depicted how mental health was a few years ago, or we kind of just would leave you in the existence of insane asylums. In the difference between mental health and mental illness, some of the simplest is just to look at what is mental illness. So mental illness are official psychiatric disorders. These are your medical diagnoses which are found in the DSM. And these individuals have significant dysfunction. 1 in 5 Americans will have a mental illness. 1 in 10 young people will have major depression. When we talk about mental health, we are doing well. The World Health Organization actually defines this as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmary. So if we're mentally healthy, we can cope with stress. We have strong relationships. We have rational thinking. We are communicating effectively. We're fulfilling our roles: wife, husband, partner, spouse, mother, teacher, nurse, whoever you may be within the community. You have good self-esteem. Bear with me. My mouse is clicking buttons that I don't want him to. Okay. Mental illness. So we talked about this originally, that it's the definable diagnosis, and these diagnoses impair and affect our patients developmentally, biologically, and psychologically. So in a few different areas. They also affect our ability to think, regulate emotions, and manage behaviors. We're impulsive, we're aggressive, we're hallucinating, we're suicidal, we are talking too much, we're not talking at all, we're sleeping, we're not sleeping. Kids are not meeting their developmental milestones. Our brain, our chemistry in our body is changing when we have these mental illnesses. All mental health is on a continuum. For the most part, most of us are going to spend our life in that mental health section, right? Where we have a little stress, because a little stress is good, but there's not too much going on. However, if something happens, we don't sleep, we get into a fight with our spouse, we fail a test, we wind up into this maybe mild, moderate. And the thing is, we can go back and forth. I get a good night's sleep the next day and I'm back to being mentally healthy. Now, when we have that marked distress, when we have that chronic impairment, whether it's a crisis, a tornado came and destroyed my house, a diagnosis of schizophrenia, hallucinations, bipolar, that is when we go into mental illness, right? It's chronic, it's disabling, we can't do anything. We looked at Mrs. M throughout this. I'm not going to kind of go over her too much, right? Troubled son, teenager, what are we going to assess for her? Is she thinking rationally? Is she communicating? How is she handling stress in the past? What's her self-esteem like? Is she functioning as a wife, mother, daughter, employee, whoever? So we went over a few risk and protective factors. So risk factors increase the chance that we will have a negative outcome. Protective factors increase the chance that we will have a more positive outcome. So we do have some biologic and genetic factors. A lot of our mental illnesses are genetics. Alcohol use disorder, 60% heritability. And most, you'll see, of our mental illnesses carry a very similar high heritability rate. Resilience is that ability to bounce back. It doesn't mean you're not affected by stress, but when stress happens, you can cope with it, you can overcome with it. We do have social and economic circumstances, lower economic lack of access to positive schools, to role models, to healthcare. What is your family like? All of those things can negatively, what is your peer group? Who are you hanging out with? Can affect both positively and negatively your mental health. Environmental factors, political climate, our individual culture. Some cultures are not going to talk about suicide. Some are going to very much demoralize mental health. Is something wrong with you? Your culture, where you live, that environment, your access to healthcare. Do you live in a healthcare desert where you have to travel very far to get mental health care? What is the safety services like? The diastasis stress model is something we'll see throughout the quarter. And this is really that nature versus nurture. So when we look at that predisposition, you have that along the bottom, you have a family history. So if everyone in your family has anxiety, it does not take much for you to manifest disorder. If you don't have that gene, that genetic, right, usually that first degree relative, it's going to take a lot more stress for you to have this disorder. Um, a lot of the problem with mental health, when we look at it, that stigma, it's all in the head, that all of these are under someone's control, but really they're not. Um, it's a play of both genetics and stress, nature and nurture. So when we looked at what are Mrs. M stressors, right? Depression disorder can be both genetic and biological, seeing changes in her body, but it also does have a genetic component. She's not sleeping and she's also stressed. If we're talking about that health insurance, my health insurance is not going to cover it. And that takes us into what we have coming on next. The brain is new. We did not really see or talk about mental health, honestly, until the 90s. And that's where George H.W. Bush really started making everyone aware of, like, hey, neuroscience, brain research, we are understanding stuff, right? We've made advances in Parkinson's and Alzheimer's. We understood neurotransmitters and neuroimaging. And the Surgeon General's report on mental health in 1999 was a huge one. Basically called it a crisis, said we have this stigma, and we have to tailor treatment to meet the needs of Americans with special attention to elderly, to gender, to race, ethnic, and culture. And we said that in 99, so 25 years ago. We also, in that 1999 report, he said that most who need treatment will not seek it due to lack of access, hope, optimism, and lack of financial, that we need to reduce those financial barriers. The Genome Project, we mapped the genome. I'm hitting buttons today, y'all. Bear with me and forgive me. We kind of understood more about what's going on, that DNA that is happening. New Freedom Commission on Mental Health basically says, like, hey, look, we need a better delivery for care. We need to diagnose early. Institute of Mental Health basically said there's a huge gap between what should be happening and what is actually happening. So we have some specific healthcare for mental health funding. So the Mental Health Parity Act is in 1996. Parity means equivalence. It basically says your insurance company is going to provide equal treatment for coverage of psychiatric disorders. So it covers something physical. It should also cover something psychiatric. Having worked in this field for about 15 years, doesn't always happen, especially when I worked with some of those pediatric patients. But it should be happening. The Affordable Care Act offered a lot of patient protections, covered for most uninsured Americans, expanded eligibility for Medicaid. Didn't go so well. Texas didn't adopt a lot of it, but we tried. Health insurance and staying, insurance mandates. You can stay on your parents' health insurance, pre-existing conditions, which are all really good for mental health if it's working, because these tend to be diseases that are diagnosed younger and they're chronic. So someone with schizophrenia is always going to need coverage, and now an insurance cannot deny that coverage. So when we talked about Mrs. M earlier, one of her complaints was about insurance. What does the Mental Health Parity Act provide? And that answer is going to be D, equal coverage for mental health disorders. The rest are from the Affordable Care Act. So we talked about what the DSM is. Again, this is a book that our psychiatric providers, our psychiatrists, NPs, PAs, they are going to use. And it basically identifies disorders based on criteria, and it serves as a tool for collecting a bunch of the data about these disorders. So this is an example of what one looks like for borderline personality disorder. And we can see a quick summary of what it is, and that we're going to have 5 or more of the following. So we are going to look at these 9 criteria, and if our patient checks off boxes for 5 of them, then they have a diagnosis of borderline. And that is, at the simplest, how the DSM works. We have a few different types of levels in psychiatric nursing. So we can have an RN, or honestly even an LVN, who works in any general or specialty area. If you choose and you're working in psych, if you have that certification, you take that test, then you can actually be a psych nurse, where you're like, yes, I am working in psych, right? So if you're working in maternity and you deal with psych patients, you're not necessarily a psych nurse. If you are the ones who are like me and you're like, I'm going to go work in mental health, then you can say, hey, I am a psych nurse. Advanced practice, so these are nurses who have a master's or a doctorate. They use the abbreviation PMH APRN, APRN being an advanced practice registered nurse. The other acronym you see is PMHNP, Psych Mental Health Nurse Practitioner. and they can diagnose, so medical diagnosing and prescribing of medications. So nursing standards and process of care, 1990s Institute of Medicine say, hey, look, we got to get things better. Patients are dying. And we've really looked at that safety and quality of healthcare. We want to provide that patient-centered care. We want to have teams. We want to keep using that best practice, constantly trying to improve, right? Things that we learn quickly sometimes become outdated. And then informatics utilize all of that technology that exists nowadays to be able to have better and safer care. So our nursing process in mental health is very similar to our nursing process anywhere else. One of the difference, and again, this is in the later half, but before we do our assessment, we have to develop a relationship with the patient. So I'm going to come in, I'm going to develop a relationship with that patient, and then I'm going to start into my nursing process. Our assessments are a little different because I don't necessarily care about your lung sounds unless we have a problem. Our exam is going to be focused more so on our patient's mental status. And that mental status exam we'll talk about briefly, we'll go through it a lot more in clinical, is the exam, it's our assessment. It's what we're doing every day in our patient. Psychosocial goes into a little bit more about like, hey, what's going on in your life? Are you homeless? Are you fighting with your family? Are you in school? Do you have legal problems? Our diagnoses for nursing and mental health are very similar to what you're going to do elsewhere. It's going to prioritize our care, and oftentimes it's going to be right risk of harm to self, others, suicide. And I know risk is a potential problem, and in med-surg we tell you not to use those potential problems. However, in my realm, risk of suicide is not a potential problem. It is the actual problem that has brought the patient to the hospital. We identify our outcomes based on that diagnosis. If I'm doing risk of harm to self, my outcome that I'm going to want is patient does not hurt themselves. And then I'm going to plan and implement my care. I'm going to round on the patient. I'm going to take away sharp objects. I'm going to develop a therapeutic relationship. I'm going to teach them coping skills. And then we're constantly going to reassess and revise. If my patient achieved their goal, what is something the next day that we can do a little bit harder to keep them moving forward? We do have some considerations that we must make depending on the age of our patient. If we're talking about children, oftentimes we can just observe them. And we can get a lot out of just watching them play. We can, if they're able to answer, talk about feelings and emotions. Whoever the parent and caregiver is can give that collateral information that the kids often can't. And we do have to look at other sources of information. What is the teacher saying? What is the coach saying? What is the youth group leader saying? If possible with kids, we want 3 different interviews. We want the child by themselves, the parent by themselves, and the child and parent together, because we need to see those caregiver-child interactions. When communication comes into play, remember we're thinking NCLEX, not real life. Language barriers. If the parent does not speak English, we cannot use the child as an interpreter. We have to get an official interpreter. And then we just have to make sure we're using language that the kid understands. Adolescents, the big concern is confidentiality. We do want to make sure adolescents know, hey, look, we're not just going to tell everything to your parents. However, those things that are dangerous, that is what we're going to have to let them know. Suicide, homicide, any type of abuse. We do have to share with the parents, and we have to remember, going back to kids too, we are mandated reporters. This little HEADS acronym is just a few things that we would want to look at and think about when we are assessing these adolescents. Older adults, we cannot stereotype. We have to be aware that medical causes can imitate psychiatric illnesses. So hypothyroidism can make someone appear depressed. Hyperthyroidism can give us a perception of anxiety. We may have to give this patient longer, right? Cognitive slowing, longer to answer those questions. And we do have to realize how a lot of their physical illnesses and their motor deficits are impacting their mental health. If our patient is in chronic pain, that is going to make them depressed and anxious. They can't do the things that they used to do. And oftentimes older adults, they're not going to want to talk about their feelings and emotions, so we may have to use that silence a little bit more. Give them time to think and answer. So in our psychiatric assessment, the very first thing we want to do with all of our psych patients is develop a relationship, establish that rapport. Because if they don't trust us, if they don't want to talk to us, they're not going to share their deep, dark inner secrets. We do a brief review of systems. So when I say that, I mean, hey, any problems going to the bathroom? When was your last bowel movement? Any problems urinating? Can you walk? Can you talk? Any breathing problems? Any headaches? Like very quickly, just over each symptom. So the mental status exam is the biggest part of what we do. What do they look like? Are they making eye contact? Are they dressed appropriately for the weather? What is their behavior like? Are they constantly moving? Are they moving really slow? Are they just laying there? What is their speech like? Are they talking really fast? Are they talking really slow? Are they rhyming? Is there no speech at all? So mood is subjective. It is what the patient says. So how are you doing today? What is your mood? I'm happy, I'm sad, I'm angry. Affect is objective. So affect looks at what the patient's facial expression. Is their face moving, or is it very flat? Where they're telling you they're happy and their face is just like, ooh. Disturbances of thought, perceptual disturbances kind of come in together. Are we having hallucinations? Are we having delusions? Are they saying stuff and you're like, I can't follow, none of this makes sense in any way, shape, or form? Cognition, are they oriented? Can they concentrate on the conversation? How is their memory? What is their insight and judgment like? Do they recognize that there's something wrong with them? And then always harm to self and harm to others. So further in this assessment, we also have to look at spiritual and religion. This is often overlooked. However, especially when we're talking about mental health, there is a big cross between spirituality and religion. So spirituality is more so how we find hope, purpose, right? That sense of peace in the life. And religion is more organized. Those external system and beliefs that we have. Same thing with culture. If our patient is from a specific culture, depending on how they look at mental health, are they seeking out healthcare? Do they have a negative impact? What is going on? Social, are they forming relationships? Are they meeting with other people? Are they having conversations? What is overall happening in their life? We do have some rating scales. This one on the screen is the PHQ-9. It looks a lot of kind of depression. Are you not concentrating? Are you down, depressed, and hopeless? Do you have trouble falling asleep? And it is very much a super simple, anyone can kind of administer, or it can be self-administered to kind of give a quantitative number to what is going on. We do have others for anxiety, substance abuse, psychosis that we will see throughout the quarter. So again, we've already talked about nursing diagnosis. We got our potential problem, the related, and the characteristics. So this example, our potential problem is ineffective coping. Our related factors related to alcohol abuse, and the defining characteristics, what tells us, as evidenced by patient stating, I drink when I'm stressed and depressed, it takes the edge off. We then will come up with outcomes. Hey, I want my patient to try 3 new coping skills today. I'm going to talk to my patient to identify triggers, educate them to take PRN medications as soon as they start to feel anxious. I'm going to teach my patient 2 new coping skills, whatever it is we're going to do. So documentation, this again goes into NCLEX, not real life. So narrative charting, descriptive statement, patient status, chronological order throughout the shift, right, supports assessment findings from flow sheets. A lot of times is that charting by exception, where we're only charting kind of what is wrong. SOAP notes, SOAPy charting, problem-oriented charting, a lot of times we see that more with the providers. Subjective, objective data, then our assessment, and then a P for our plan if we need it. In mental health, we're going to do more of that narrative charting. When we think about charting considerations, right, we're going to chart on time as things happen. I'm going to not chart early. So I don't want to chart patient got a medication before I went into the patient room and actually gave it to them. I'm going to chart facts. So I'm going to document, hey, XYZ happened with the patient. Patient's pacing and wringing their hands. I'm not going to say, right, that opinion, patient appears anxious, because patient appears anxious is my opinion, not what the patient is saying. Subjective data, if the patient says, I am anxious, my anxiety is a 7 out of 10, that I would document, right? And subjective goes in quotes. What we're doing to the patient and their responses. No blanks. We're not going to chart incident report filed. Documentation can be used in court. It can be used to help insurance companies. It can be used to help communicate among different parties. If a patient has a problem and thinks there's something wrong with their record, they can request that it gets updated. So that therapeutic relationship, so this is what we covered today on Tuesday. So that nurse-patient relationship, It's patient-centered. It's all about the patient. We want them to talk. We want the patient family to participate if we can. And that how we form that relationship with the patient is that basis for everything that we are going to do. Many of our mental illnesses have that low self-esteem, poor self-image, right? We're not necessarily adhering to treatment. So our goal in forming this relationship is to use our therapeutic use of self, our distinct personality, to form bonds with this patient, to make them feel better, to get them to make the decisions. When we look at this, we are going to see dignity and respect. We're going to see information sharing. We're going to see collaboration. That is what we want. So the goals and functions, we want the patient to want to talk to us. I want them to tell me if they're having a bad day, if they're not feeling good. I want the patient to make their own decisions related to problems. I am not solving the patient's problems. I can help them. However, they need to solve their problem. If the patient is doing something that's self-defeating, if they're constantly drinking, if they're calling themselves stupid, I want the patient to be able to recognize that that's going on and help them look at their self-defeating behavior. There are times where we may have to help with some of that self-care with our patients, but for the most part, I want the patient to do it on their own. You're going to do your own ADLs, you're going to make your own bed, all of that fun stuff. I'm going to teach you about meds and symptoms. These are the meds the doctors have ordered. These are the side effects. Take as prescribed. Hey, you're having this symptom from this diagnosis. This is what we can do to help it. And we want to work with the patients to achieve kind of their best possible self. So we have a few types of relationships, some being social or therapeutic. Socials are friendship. We're hanging out, we're socializing, we're enjoying ourselves, right? We're having our mutual needs met. In a social relationship, right, if we have two parties, me and my friend, both of our needs are being met in the relationship. In a therapeutic relationship, we are maximizing our communication skills, our understanding of the human behaviors, personal strengths, everything that we can do to enhance the patient's growth. The whole focus of the therapeutic relationship is on the patient. And that is consistently the patient's needs, not ours. We have those clear boundaries. We want the patient to have coping mechanisms. We want to have this change. And the roles should stay the same in a therapeutic relationship. So boundaries happen. And we should have well-established boundaries, especially in our work environment, but it does not always work like it should. So we have some nurses where it's like, hey, I don't know what they're going. They're not kind of following through. They're not really spending time with the patient. They're sitting at the nurse's station a lot. Then you have the overly involved nurse, and they're not completing all their other tasks because they're spending so long with the patient. Coworkers are angry because, hey, I have to pick up your slack because you're not doing it, right? Maybe they're constantly asking for help. And other patients start to notice, hey, Nurse Sally is always spending time with patient Jim. Why is that happening? So we have to meet in the middle where we need to be involved, but not too involved. So blurred boundaries in healthcare, if we have social relationships with our patients, it's a no, it just should not happen. When our patients discharge, even if we thought they were super cool, we don't follow up with them. And we also need to make sure that patients' needs are met and not the nurse's needs. If I'm coming to work and I'm venting and I'm talking to the patient and my needs are being met, then the patient's needs are not being met. Transference and countertransference are two Freudian terms. So transference is when the patient relates the nurse to someone in their life previously. So the nurse reminds the patient of their mom or their ex-wife or their best friend. And the patient kind of treats the nurse or the healthcare provider a little differently because, well, you remind me of my mom, she's super sweet, so I'm going to seek out more attention from you. Countertransference is the opposite, and it's the patient reminds the nurse or healthcare provider of someone from their past. No one can understand the patient like I do. I have a special needs kid, right? I have a kid with autism. I can take better care of this patient than any of the other nurses. Or maybe the patient reminds me of my sister and I hate my sister, so I'm going to avoid taking care of her and give her the minimal amount of care. Self-awareness, we talked about, is that big one. We need to know what's important to us and what we can do. There are a lot of hard and complicated situations with patients. What if we have a patient who is being charged with child abuse, right? Sexual molestation, sexual assault, rape. How do we go? What if we have someone who's being convicted of murder and they are a patient? We still have to take care of them and kind of be aware. And sometimes we need to know when to tap out. Hey, look, I can't take care of this patient. Sometimes we have to realize that that is a thing. So our whole goal in this nurse-patient relationship is facilitates forward movement. In class, we talked about Hildegard Peplau. We'll go into her a lot kind of with theory, so I'm not going to talk about too much with her now. But she's very much that, hey, look, nurses are people, we have brains. We can do things with our patients, right? Not to our patients, but with our patients. We can form those relationships. And she has an established, right, back in the 50s, the 4 phases of the nurse-patient relationship. So the pre-orientation phase is before we even meet the patient. I get shift report. I get a phone call from the ER that a patient is getting admitted. In the orientation phase, I establish rapport, I figure out what the patient wants to be called, I set the parameters of the relationship, any contracts, confidentiality, terms of termination. I'm looking at like, what are my goals? Like, what is going on? Why are you here in that orientation phase? The working phase are our interventions. I'm maintaining that relationship. I'm gathering data in the working phase. I want the patient to problem solve. I want them to use language. I want to teach them coping skills. It's all of the things we do with the patient is in the working phase. The termination phase is the end. Hey, thanks for being here. All of this stuff happens. We have all these new goals. You've done all this great stuff. Thank you so much for coming. Make sure you follow up with your provider. Head to the ED, call 988 suicide hotline if you have any other problems, right? So the termination phase is the end. We're not going over new goals, but we're talking about what we have achieved with our goals. So we talked about the good nurse that our patients would say. We talked about our good coworkers, genuineness and empathy. We have to treat everyone as they deserve to be treated. That genuineness, that positiveness. Just because your patient is homeless and just because your patient's abusing drugs should not affect. It should not affect how we are treating them. If the patients can know if you're there just kind of to be there, if this is just a job, then we probably need to look at what else is going on, right? And I know mental health is difficult for all of us, so I'm not saying all of you, but if you're like mental health isn't my jam, we still need to treat people respectfully. Watch this cute little video on empathy, and then we went into therapeutic communication. So this is all that background, right? We have a few different parts. We have someone who is sending the message. We have the message. We have how we're sending the message. And we have the person receiving the message. If there's a breakdown in any of these, it can affect communication. So personal factors, if our patient has a psychiatric disorder, our patient is psychotic, our patient has intellectual disability, our patient is depressed, right? Maybe we're just really tired. Maybe we're having a panic attack. Language barriers are a big one. We have to get that professional interpreter. Remember, this is the NCLEX and not real life. If we have a patient who speaks another language, we're not asking our charge nurse, we're not asking our friend or another patient, we're getting that interpreter. Education levels, we know I made fun of my husband, gotta love him for that, right? Just because someone is a lawyer doesn't mean they understand healthcare. But then we also have to understand that healthcare isn't of itself. Some of our patients may have education levels in elementary school, even though they are an adult. They might not be able to read and write. So we do have to take that into concern when we are communicating. If you've ever been in a psych unit, it is noisy. There's no privacy. It is probably freezing with super bright lights and the most uncomfortable chairs you've ever sat in your life. And that can all affect how we're willing to open up. In these relationships, we have oftentimes an unequal relationship. So we have a different power level. We have, as the nurses, more power over our patients, right? We control everything that happens on those psych units. It is not symmetrical. It is not even, especially when the patient comes in. As the patient starts to recover, we tend to get a little bit more equal, but it will never be symmetrical. Symmetrical is something we're usually going to see like with our friends. So we have verbal and nonverbal communication. Verbal is what we said. Nonverbal is how you said it. Is it your tone, right? That first time you tell your kid to pick up the toys versus the 20th time. Is it what our face is doing? Are we giving that look? How are we standing? Are my arms crossed and I'm very closed off? Verbal and nonverbal should connect. If it doesn't, we definitely want to take a look at it. We talked about some therapeutic communication techniques. And once we get to the end, I'm going to pull up the textbook too to look at some of the different ones that we looked at. So silence. It can be beneficial. The patient is the one who controls that silence. It gives us a time to gather thoughts, to reflect, and we have a lot of cognitive slowing in mental health, so we want to give people extra time. Active listening, we need to be engaged. We need to be paying attention. We need to be not documenting, not carrying on other conversations, not looking at our phone, but focused on the patient. We have a few different clarifying techniques. Paraphrasing, we restate what was said back, just we use different words. Restating helps us kind of understand, and we're going to use similar keywords. I hear you saying that you slept like crap last night. I'm using the exact same words that my patient said and restating it back. Reflecting brings in thoughts and feelings. I hear you saying that you slept really bad last night and you're feeling anxious this morning, and that's causing you to feel anxious, right? The patient said they're sleeping bad. I am now adding in that anxious or depression. Exploring, we want to know more. Can you tell me more about this? Let's talk more about your childhood. Let's talk more about that fight that you had. And I'm asking the patient to go into more depth about something that they brought up. Two types of questions, open-ended and closed-ended. Open-ended provides more details. Closed-ended are those yes and no. Both of these are good, but if we use too many questions, especially our closed-ended, it starts to feel like an interrogation. We want to have a conversation, not an interrogation. Projective questions are what if. Sometimes I think your book talks about like the miracle question. What if you woke up tomorrow and everything was different? How? What would that look like for you? And it can help our patient kind of look at really what they want. So questions are good, both open-ended and closed-ended, but we have to use them sparingly to not interrogate the patient. Some of our non-therapeutic techniques, excessive questioning. Like I said, it's not respectful, it's an interrogation. I know in the real world, sometimes it's like, look, I got to get through this admission assessment. I always, in kind of real life scenario, would let the patients know, like, I apologize, I have to ask all these questions, I'm so sorry. Approval or disapproval, and the same thing with giving advice. It is not our place. I definitely want all my patients to stop doing drugs, but I want my patient to stop using drugs because they want to stop doing drugs. If they are doing it for me, that is wrong. If they're doing it for someone else, that is wrong, and they're not going to stick with it. Giving advice, I need the patient to make their own decisions. And y'all looked at me like I was crazy in class when I said this. The patients have to figure out their own problems. I cannot solve all the patient's problems because I'm not always going to be there. I want to promote their problem solving, but I need them to solve their problems. I want to give them the tools and have them build it. Why questions just demands an explanation. Why did you do that? Well, why did you do that? Why did you come here? Well, what happened that brought you in? Right? When we switch it to kind of a what, oftentimes it kind of softens the question and it doesn't quite seem like we're pointing fingers at the patients. Other things we have to look at, especially when we're talking about culture, communication style, some people use more hand gestures. Some people talk faster. Some people talk slow. Some people are just going to stay calm even if they're freaking out inside. Our culture does very much affect. One of the things we didn't talk about is that kind of space when it comes to communication styles. Some cultures are going to keep their distance and some cultures are going to stand closer. Intimate versus personal distance. Eye contact. Some cultures consider direct eye contact to be disrespectful and improper. We don't want to force someone to make eye contact for whatever reason. And we do have to be mindful. If I have someone and culturally they're not going to make direct eye contact, that is not like a negative finding. That is not well, they're not making eye contact. Now, if I have someone who within their culture eye contact is made and they have autism and they're not making eye contact, that would be a finding. But if it's like, hey, my patient they just immigrated from this culture that does not make eye contact, that is not necessarily a negative finding or a concern. Therapeutic touch is iffy in mental health. Most other areas, right, we talk about like hospice or elderly, are going to see touch in that nurse-patient relationship. However, in mental health, we tend to stay away from it. Some cultures can view touch as an invasion of privacy, and then when we throw in our mental health conditions, it is just better to not touch. Cultural filters oftentimes look at that prejudice and that bias that's going on. What are we paying attention to and what are we ignoring? So we just need to be aware. When setting up the interview, we want the patient to set the pace, no matter how slow it may be progressing. When we talk about the setting, we want somewhere secure. We want maybe like a conference room, someone with privacy, but where we're still kind of able to be seen by other people. Seating, same height, not face to face, because that makes an interrogation. We want to make sure the patient has access to the door and that the nurse has access to the door so we are not trapped. We're going to make introductions. We're going to talk about confidentiality, how the patient would like to be addressed. And we really want to start with a lot of those open-ended, those kind of like general leads. We'll talk about those when we look at the book, right? Where should we start? Tell me about what's been going on. Because when we use those very general lead, like broad openings, when we use those broad openings, where would you like to start? That lets the patient direct the conversation. What do you want to talk about today? Not necessarily what I want to talk about. We looked at these questions in class. Which of the following example illustrates a boundary crossing in the nurse-patient relationship? Give y'all a second. And honestly, some of y'all disagreed, but this answer is A. We can't spend extra time with patients regardless. The patients need to get any kind of even amount of time, which I know is different, but the patient very much has to figure out the situation. I can't give him the answer. Teenager begins to cry when talking with the nurse about not being able to make friends. What is our most therapeutic intervention? So this one is sitting quietly with the client. That's silence. The rest of these, when we look at some of those negative therapeutic, right, dismissing feelings, changing the subject, giving advice. Patient discloses several concerns with associated feeling. If the nurse wants to seek clarification, which comment would be clarification? So for this one, the answer is going to be C. We are asking the patient, right, am I correct in understanding that? And then whatever it is to make sure we understand what is going on. During an interview, a patient attempts to shift the focus from their self by the nurse by asking personal questions. What do we say? And the answer for this one is that D. The time we spend together is to discuss your concerns. We can do, and this was in one of that first question, that limited kind of answering questions. Sometimes if we self-disclosure, if we share a tiny, tiny, tiny bit, the patient is more likely to communicate with us. It helps build that relationship. What principles should guide the nurse-patient in determining the nurse-patient relationship when we determine the extent of silence? So this one, what determines the extent of silence in a relationship, is going to be C. It provides that reflection. Why do we do a mental status exam? What is the primary purpose of the mental status exam in the psych mental health nursing assessment? So the mental status exam is A. It really looks at cognitive process. Patient's physical condition vitals, that is medical, not mental status. Psychosocial history is done in the psychosocial assessment, and then past medical history, present medical condition doesn't relate to the mental status exam. What is the primary purpose of documenting a patient's progress in care in a medical record? The rest of this stuff occurs. However, the one we're specifically looking for, why we're doing it, is D, to communicate. And the last question, which of Peplau's nurse-patient relationship, which phase is the initial encounter between the nurse and the patient during which introductions, rapport building, and confidentiality is discussed? And that answer is going to be B, the orientation phase. Now I'm going to switch over real quick. We looked at this in your textbook. So this, for those who have the most up-to-date book, is table 9.2 on page 141. We talked about a lot of these: silence, offering self, hey, can I spend time with you? Can I sit and talk to you? General leads and broad openings are two really good ones. Broad openings is how we start, and it lets the patient kind of navigate the conversation. What are you thinking about? Where would you like to begin? We watched that little video in class, and there was a lot of those general leads. And then go on, tell me more. Um, it shows, it's kind of that active listening. It shows that we're interested and that we want the patient to continue. Making observations. I notice you are pacing. Are you anxious? We're bringing the attention to behavior that the patient might not notice. Restating, we talked about. Reflecting is very much getting the patient. What do you think you should do about this? Because again, I'm not making your decisions. Let's see. Giving information is a big one. This medication is for this reason. These are the side effects. Be careful. If this happens, call your doctor. Exploring. Tell me more about it. Could you describe this more fully? Let's go into more detail. Is there something else we need to learn more? We're not trying to probe or pry. We have to respect our patient's wishes, but if we need to know more about something. So more therapeutic techniques. Voicing doubt. Let the patients know that maybe something isn't real. The example I talked in class is, hey, if I have a patient and they have postpartum depression, I'm the worst mother in the history of all mothers, right? That's hard to believe. I don't think that's the case. That is therapeutic. Let's see what some other ones. Summarizing, we talked about encouraging formulation of a plan of action. We want the patient to come up. If you say you've been struggling with your, talking to your mother and you have family therapy today and you're anxious, what are some steps that you can take? What can you do during family therapy to ensure a positive session? Non-therapeutic techniques, we don't give advice. The patient needs to make the decision themselves. If I have someone who is getting abused and they are in a relationship and their husband is extremely abusive, I cannot tell them just to leave. I can give them the steps and tools, but it has to be their decision. I cannot minimize feelings. If your patient says that, hey, I'm so depressed, I can't get out of bed, my life is over, we can't say, well, everyone gets down in the dumps sometimes, because that kind of disrupts it. Any of those cliche type statements we're never going to say. And that kind of goes along with that falsely reassuring. Everything will be okay. Because we don't know if everything will be okay. We're never going to use why. We're not going to do excessive. We're not going to give approval or agree or even disapproval. It has to be the patient's decision. They have to make the decision to do it on their own. And then we can't change the subject. I'd like to die. Hey, did you see that storm we had the other day? Wasn't it crazy? And again, in that kind of real world example, in that changing the subject, don't think that you need to sit there and get abused by a patient if your patient is being sexually, racially, whatever inappropriate. That is an okay time to change the subject. However, when we are having an appropriate conversation, both parties being appropriate, we don't want to invalidate the patient's feelings. I know this was a lot, and I did super fast. My goal was an hour, and I'm less than 45 minutes. But for those audio learners, those of y'all who have a commute, very quickly what we went over today. If y'all have any questions, let me know. Otherwise, I will see y'all next week.